This morning, I am very happy to introduce Dr. Diane Christopher. Dr. Christopher joins us today from the University of Colorado, where she's an Associate Vice Chair of Obstetrics. Dr. Christopher completed medical school at the University of Colorado, followed by OBGYN residency at McGaw Northwestern University in Chicago. Since joining the faculty at the University of Colorado as an assistant professor in the generalist division in 2016, she has initiated quality improvement projects focused on standardization of the first obstetric visit and hypertensive disorders of pregnancy. Her academic focus is on quality improvement with an emphasis on addressing socioeconomic disparities in healthcare, using innovative approaches to improve healthcare outcomes by improving patient engagement. Please join me in welcoming Dr. Christopher this morning.
Thank you so much for that very kind introduction. I'm really excited to be here today. And as she said, we're going to be talking about America's rising maternal morbidity and mortality. And we're going to talk about, is quality improvement a potential solution to the problem? So first I'm going to go through my disclosure. So way back when I bought some personal shares of the Illumina stock, and I need to disclose that because Illumina is the company that runs cell-free DNA. And so we all use it every day. So we've got learning objectives here, but I'm going to go through these in a little bit more of a visual way. So we're going to talk about where are we going today and how are we going to get there. So first off, we're going to talk about understanding the problem, and that's step one. And this is important because step one of quality improvement is always to dissect the problem. And in this area, we'll review the startling statistics of maternal morbidity and mortality today in the United States. And we'll start by focusing on the mortality statistics. And I'm really going to limit most of the discussion to mortality. At this time, we'll also review the racial and ethnic disparities that we're seeing today. Second, we'll move on to an introduction of what is quality improvement. And then thirdly, we'll go through how we can overlay quality improvement principles to address the problem of maternal morbidity and mortality, where this can be productive and where it can lead us astray. And then lastly, I'll show you a real world example from the University of Colorado of a project that we did, and I'll show you where it's been successful and where we need to do more work to achieve equity. So we'll start off by just going through the definition of maternal morbidity and mortality. So the World Health Organization and the National Center for Health Statistics uses the same definition, which is helpful because that way we can compare our country to other countries. But it's a pretty strict definition. So it's death of women while pregnant or within 42 days of being pregnant, so 6 weeks. It's any cause related to or aggravated by the pregnancy or its management. It excludes accidental or incidental causes, and it's reported per 100,000. So the definition here is really trying to capture just what's happening in that perinatal, immediate postpartum period. And as you guys know, there's a lot that happens in the first year postpartum that this definition is not going to capture. So we ask, well, why is this important? I'm sure we have a somewhat broad audience. Not everyone may be an obstetrician. So why is this of any importance to us? So first of all, this is a public health metric. Governments monitor and report this around the world. But more importantly, it's not just a line on the spreadsheet of outcomes because it speaks to how our society values motherhood and birth. And we can see many examples in our country today where maternal health is not prioritized in the system. The second issue is that the rate is increasing. So up until the 1990s, maternal mortality was on the decrease. But since the 1990s, we have seen a steady increase in number. The next issue is that we're seeing some pretty striking racial disparities today. These racial disparities are widening. We know that Black women have always had higher rates of maternal mortality in our country, but racial disparities that we're seeing today are what I would determine an unacceptable high. And lastly, because we're discussing racial differences and race is a social construct, the disparity is a solvable problem. So here are some of the statistics graphically. On the left side, you'll see maternal mortality rate. And as we discussed previously, it's per 100,000. And then on the x-axis, you can see years, and over time, we see that in 1999, maternal mortality rate was 9.9, and in 2017, it went up to 21.6. So the next question, why? Why are we here? Why is this happening? And there's lots of multiple overlapping reasons. Pregnant women today are older. Pregnant women today are sicker. Maybe they're not getting prenatal care as soon as they need to. Once they get prenatal care, we take care of them. Then in the postpartum period, they lose their insurance. Then any chronic medical diseases that we diagnosed, we're not able to continue to treat. They get pregnant again and the cycle repeats. This was my best hope of organizing the information. We've got all these medical issues on the right side, access to care issues on the left side. And then I tried to organize, I think I did this slide 2 or 3 times, and there was just no way to put it together. So I topped off racial disparities on top of it because it overlays every single one of these problems. And none of these problems can really be neatly organized into a categorical or outlined. So, but the racial disparities are truly central to the problem. And so we can't really discuss how to improve maternal mortality without discussing the racial disparities. So while this slide is kind of a web, and I like to call it a mess because I think it's a mess, we're going to break down this a little bit further to understand the problem. So we're going to start by diagnoses. So when we look at what women are dying of, we have 2 different components. We have direct obstetric causes and indirect obstetric causes. So the green on the right is indirect obstetric causes. Those account for around 22%. These are medical illnesses that occur during pregnancy. So I'll give you an example. Tuberculosis in pregnancy. It's not really a medical, it's not really an obstetric issue, but it could aggravate pregnancy and death. Mental health disorders also fall into this, as does something like hepatitis in pregnancy. On the left side, we see the direct obstetric causes, and the direct obstetric causes account for about 80%. And there's enough diagnoses in some of these smaller categories at the bottom that we'll list them out, and then they go through remaining obstetric causes as 50%. So abortive outcomes, you can see at the very bottom, 4.4% is abortive outcomes. So that includes things like heavy bleeding in the first trimester, an ectopic pregnancy, which we all know can be life-threatening. The next is eclampsia and preeclampsia, 5.3%, again, not surprising. Hemorrhage anytime during the pregnancy, immediately postpartum, also placenta previa is grouped in that, 4.6%. An obstetric embolism or amniotic fluid embolism, 6.5%. And then other complications that are related to the initial 6 weeks after postpartum or after birth is 4.3%. And then this other bucket here, direct obstetric causes that are left over, is a myriad of different things. But to give you an idea, these are the diagnosis codes. So all the diagnosis codes that are O are obstetric. Some of these are things like pre-existing hypertension or renal disease, bleeding in early pregnancy that's not abortive outcomes. O22 is thrombosis, so we can see where that would go. Infections of the urogenital tract during pregnancy. And then this also includes categories like maternal sepsis and complications of anesthesia like aspiration or a failed intubation. So that kind of gives you a picture of what we're looking at from a diagnosis standpoint. Next, we'll look at maternal mortality by age. So on the left side, you see 3 bars where it says under 25. And then in the middle, it says 25 to 39. And this is the age of women. And then 40 and over. And so you can see the group of women who are under 25 have a fairly low maternal mortality rate. And that goes up slightly when you get to the 25 to 39 range. But it goes up significantly when we get to the 40 and over. And we can see the blue, the green, and the maroon all indicate different years. So year over year, it's gone up. Next, we'll move on to looking at race and ethnicity. And we see that non-Hispanic white women have a rate of 14.9 per 100,000 for maternal mortality rate. Non-Hispanic Black women have a rate of 37.3, and Hispanic women have a rate of 11.8. So this is a single point in time, so we can say maybe this was just one area, but it's still more than double the difference between white and Black women. And so then we look at the statistics 2018, 2019, 2020, and we see each year the rates are going up, and the rates go up significantly for non-Hispanic Black women. So you can see in the third column, in 2019, the rate was 44 per 100,000. And then in 2020, the rate was 55 per 100,000. So we're seeing some significant increases year over year and some significant increases for Black women specifically. So after I looked at this information, my next question was, well, what about the ages of the women overlaid with the race? And so our National Vital Statistics System had that too. And this, doesn't explain the problem away. So this is a little bit busy, but what you can see is on the left, you have ages. So the first is all ages, everyone. The second is women under 25, third 25 to 39, and the bottom is 40 and over. And then on your x-axis, we're going to have deaths listed per 100,000. So what we're seeing here is that when we get down to the area of women 40 and over, women who are non-Hispanic Black have a 239 per 100,000 rate of maternal mortality versus 72 per 100,000 for white women. So this demonstrates an even larger disparity for women over 40. So we go back to our big web and we say, well, why are there these differences? Because we have to figure out why there's differences in order for us to try to solve the problem. So we're going to move over into the left side of the slide, and we're going to talk about access to care. We're going to talk about where patients go for care, when they present to care, and medical conditions that are optimized prior to pregnancy. So access to care starting with preconception. We know that women who have untreated medical conditions are more likely to have chronic, untreated medical conditions are more likely to have advanced diseases. So women who present for prenatal care with uncontrolled hypertension predisposes them to worse outcomes. So we see these women go on to have preeclampsia, renal disease. This can lead to preterm delivery, complicated obstetric outcomes. We also know that women who are uninsured are more likely to have advanced chronic medical illness. In the United States, we know that Black women are less likely to have insurance than white women. And then unfortunately, this one is becoming a little more poignant today. 50% of pregnancies in the US are unplanned, and Black women are twice as likely to report an unplanned pregnancy compared to white women. So we can see these chronic medical conditions combined with these unplanned pregnancies. We can see how complicated pregnancy can really become. Yeah, yeah. That's a good question. I haven't either. I don't know. That's a good question.
Can you repeat the question?
Oh, sure. So the question was, is there any correlation to unplanned pregnancy and mortality? And my answer was, I don't know. It's one of the issues, so this is a little bit off tangent, but one of the issues I think is that there's a big problem with reporting, and there's been a lot of work in the past 5 years to try to improve that. So yeah. I left the reporting part out of the lecture because it's kind of its own lecture and its own thing, but we can talk about it later. So the other issue is the chronic medical diseases. So what are these? So something simple like obesity. This is reported from the behavioral risk factor surveillance system. And what's interesting about this is they go to patients in the community and they say, what diagnoses do you have? In this scenario, 40.7% of non-Hispanic Black adults reported obesity, differing from 35.2 Hispanic adults and 30.3 non-Hispanic white adults. So what's interesting about this is that this is self-reported. So if this is what they're saying, these numbers are pretty striking in and of themselves. It could even be worse. We know that obesity leads to poor pregnancy outcomes. I think this is something we battle every day as obstetricians. We see an increased risk in gestational diabetes. We see increased issues with birth dystocia, cesarean section, wound infection, depression, problems with breastfeeding, etc. So the next issue is access to care. So it seems that if you had a chronic advanced disease, you should start your prenatal care pretty early in the pregnancy. But unfortunately, the women that are getting early access to prenatal care are usually the women that either have well-controlled medical illness or no medical illness. We see from this slide, women that are in their 30s, mostly white, bachelor's degree or higher, and privately insured. Those are the women that tend to present in the first trimester. And we know this is troubling as obstetricians because early prenatal care allows us to perform screening, start aspirin, treat behavioral health issues, address food and housing insecurity. So if we're not seeing these women early, we can't provide that support. So the next question we can say, well, why is this happening? Why are we not seeing women in the first trimester? And I can tell you the story that I know, which is the one from my hospital. We did a study in 2017 that looked at genetic testing for women in our hospital. And we found that Black women were less likely to be counseled on genetic testing options for aneuploidy. So this was very concerning. We broke the data down a bit further, and we found that our Black patients were actually presenting to us much later as well. And so we thought there may be a correlation there. So in our hospital, patients present for prenatal care in their second trimester at a pretty significant rate of difference. So white women presented in the second trimester at 7.3%, Black women at 18.6%. So the other question you can say, well, why is that happening? And I'll tell you, at our institution, we are not a safety net hospital. So we will not see a patient unless they have insurance. The patient doesn't have Medicaid, they're asked to sign a waiver or pay a deposit. And if they decline to do that, then they leave, they're turned away, essentially. So we have lost opportunities that are happening regularly. Patient will then go apply for Medicaid elsewhere. Then they'll come back. Well, now we're in the second trimester. So it's really an unfortunate situation. It's something that we need to address if we want to fix this problem. So the next question is, okay, so let's say you got care. Let's say you already had Medicaid. Let's say you found a clinic, you got accepted into the clinic. What kind of care do you get? So this data is focused to New York City. And what this study found was that Black women are more likely to receive care in poorly performing hospitals. So these are hospitals that perform poorly for all races, all outcomes. There's a lack of safety protocols, there's less evidence-based medicine happening, and the estimates are that if the Black women of New York City delivered in the hospitals that white women delivered in, the morbidity rate would go down from 4.2 to 2.9%. So this came out in 2018, this paper, and just recently, about 2 months ago, there was a big initiative in New York City to start addressing this. So that's huge, huge positive. Another instance of the geographic location making a difference. So this study was just recently published, focused again on genetic testing. This was in Massachusetts. So at the time this study was done, Massachusetts paid for cell-free DNA for women over 35. But what they found was that women who were over 35 and had Medicaid were less likely to have non-invasive prenatal genetic testing based on their zip code alone. And when they broke down the zip codes, they found that women who lived in zip codes that had a higher percentage of Black or Latino women, or patients total, were less likely to have completed non-invasive prenatal testing. And so this is concerning, because now we've taken care of the insurance battle. We've taken care of the coverage battle. These patients meet criteria, but they're not getting the treatment. They're not getting the options. And part of this has to do with the types of clinics that these women are visiting, the types of clinics that are servicing this population. So besides going through all of these other individual factors, we have to talk about bias. So after adjusting for risk factors, this study was maternal mortality for Black women is still higher. So we looked at, in North Carolina, they looked at the rate of mortality between Black women and white women, and then they adjusted for gestational age at delivery, maternal age, income, hypertension, and prenatal care, and the risk was reduced to only 2.5. So still a twofold increase. So this next one, this is going to switch to morbidity. So this slide looks at maternal morbidity in relationship to comorbidities by race. So this on the left side, you see rate per 10,000 deliveries, because morbidity is described in per 10,000. And then on the bottom, you see different clusters. So in the left side, you'll see 0 comorbidities, 1 comorbidity, 2, 3, et cetera. What's interesting about this is that if you have 0 comorbidities, your race alone still shows that you are more likely to have a maternal morbidity. And we can see as you go from column 0, 1, 2, 3, that persists and worsens. So it's not surprising that patients feel this. This literature shows that 30% of Black and Hispanic women who delivered at a hospital reported mistreatment in comparison to 21% for white women. And unfortunately, you know, when we're surveyed, we also report that 84% of high-risk OBs agreed that disparities affect their practice, but only 24% believed their own bias influenced their ability to care for patients. So that's really tricky. We acknowledge that we all have bias. We know we have bias, but we don't think that we're using our bias. So that's where some of this becomes complicated. You guys are probably familiar with implicit bias training, and there's one specific well-known score. It's called the IAT. And we know that if we give the IAT and then we do implicit bias training and then we give the IAT again, we know that the score can decrease. But what we don't know is if that decreased score relates to changes in how we take care of patients. So now we look and say, all right, so we've got a problem here. Let's look at what's happening around the world. So in the United Kingdom, they spend 10% of their GDP on healthcare, and their maternal mortality rate is 7 per 100,000. In the US, we spend 16% of our GDP on healthcare, and our maternal mortality rate is 19 per 100,000. So we spend a lot of money but somehow we're not producing good outcomes. So we can all agree we have a big problem. And at this point, we got to figure out how to fix it. So we can either spend more money with the current system, and that's essentially what we've done in the past. We've put more healthcare into the healthcare system, but we haven't seen many different outcomes. And then the other option is to approach the problem differently. And this problem has been approached in a couple of different ways. One is to increase diversity in the physician workforce, very important. Another is to figure out how to increase the effectiveness of implicit bias training. And then the third is to implement quality improvement. And so today we're going to focus on the quality improvement piece. All right, so we are now going to switch gears and talk about what process improvement is, what quality improvement is. So quality improvement, process improvement originated in factories. And the idea was, how do you produce a really quality outcome cheaply, quickly, and make it work properly? I like to explain this by the analogy of sandwich shops, because I think you guys all are familiar with it, something everyone can relate to. On our campus, we have a Subway sandwich shop, and it's always the fastest place to get a sandwich. It's always the fastest place to get lunch. I don't always want a Subway sandwich, but sometimes it's all I have time for. So it turns out this isn't a mistake. So they train their sandwich artists. There's 5 seconds for selection of bread, 15 seconds for a selection of meat, 5 seconds for your type of cheese. Then they ask you if you want it heated or not. 25 seconds for the heating process. Remove it, go on to the veggie section. And then they go through, veggies, sauce, toppings, wrapping. And then they have another one of these for their payment process. So it's calculated, it's measured, and it's effective. So this is a really simple way of describing that process improvement. Now, typically we use the term process improvement when we're talking about manufacturing or something like this, but quality improvement is the application of process improvement into healthcare. So I'm going to go through the official definition for you, and then I'm going to give you my definition. So the first official definition from Medicare and Medicaid: standardized processes and structures to reduce variation, achieve predictable results, and improve outcomes. So my definition is, make it easy for people to do the right thing. If it's hard or inconvenient to do the right thing, it's less likely to happen. In the example of the Subway shop, if we take the mayonnaise and we put it in the refrigerator in the back of the Subway shop, a lot of people aren't going to get any mayonnaise because it's not easy, it's not convenient. The second is we have to develop logical processes. So put the mayonnaise next to the other vegetables and find a way to keep it cold. Build in redundancy with intentionality. So maybe there's 2 bins of lettuce because we go through the lettuce twice as fast as the tomatoes. That's intentional. And then measure outcomes. So at Subway, it's how fast can they get you your sandwich and how likely is it to be accurate? In medicine, it's going to be whatever outcome we're studying and looking to achieve. So post-op infection rate, NTSV rates. Medicine, it's common that we'll do the first 3 steps, but we can't call it quality improvement if we don't study the before and the after. And lastly, we have to repeat. So once we develop a process, we have to test it. We have to see if it works. If it doesn't work, we have to change it, and then we have to test it again. And then we do that over and over and over again. And even if it works for a little while, something's going to change. Something will change in the environment, and the process will have to change again. So now we're on to part 3. How can quality improvement address maternal mortality? So for reducing variation, we can eliminate bias. If we achieve predictable results by developing systems and processes, and we can improve outcomes, which would be to reduce our maternal morbidity and mortality. But there's still some other components. Reichman in 2021 published this paper that looked at this specific question: can quality improvement be used to eliminate disparities? And they came up with three possible outcomes. We can improve the outcome for all populations equally, thus preserving the disparity. We can improve the outcome for all populations, but a greater emphasis on the advantaged group, which would be widening the disparity. Or we can improve for all populations with a greater impact of the less advantaged group and thus narrow the disparity. So you guys have probably seen this before, preserving the disparity on the left. We've given support to every person on the left side of the picture, but the support doesn't provide the right support for everyone. On the right side, to narrow the disparity, we would give different supports to different people in order to allow everyone to see over the fence. So now we're going to move on. So this is the real world example. So this is where I practice at the University of Colorado. We're located in Aurora, which is within like a mile of the Denver border. So it's basically Denver metro area. This building in front that you see is our medical office building. And then our hospital is there. And then on a super nice clear day, I suppose the mountains look like that. I've never seen this view. But I found this, I thought it was a nice representation. So our task was to try to figure out how to optimize the first prenatal visit. And the reason why we wanted to work on this is because there's a lot of topics, and it seems like every time you look at it, the topics have expanded. It's a struggle for providers to get through, and it's also overwhelming to patients. When I was the medical director for my group, if a provider had more than one new OB patient per session, there were all kinds of complaints and angry emails because it took too long. I mean, we did put everyone behind, and they're like, I don't, this is ridiculous, right? We can't do this. But this is a high impact visit. This is a visit we've got to get right. And the reason why we have to get it right is because we want to make sure we implement all of our evidence-based proven interventions. We know we can do aspirin to prevent preeclampsia. We know we can optimize outcomes with screening for gestational diabetes, intervening on substance use, support for intimate partner violence, resources for healthy food, and ensuring patients can get to the clinic. So I'd been thinking about this project for several years, and I kept having patient interactions that propelled me to do this more, because it's a big project, it's a big undertaking. But I'd have situations where I'd think, geez, I wish I would have known this about this patient 10 weeks ago, and we would have been able to address this issue. Or I have another patient that really sticks with me. Just in casual conversation, she told me that she had recently been incarcerated. And at the end of the visit, I thought, how did I get here? I have no idea how I got this information. And I have no idea how many other patients I've missed this on. I also find that when I ask patients specifically, do you want to speak with our social worker about resources? I get a yes. But oftentimes, patients don't want to ask directly, even though they might need the help. So how do we ask the right questions at the right time to optimize pregnancy? So like any good quality improvement project, we studied this. We followed 51 patients. We looked at what we did well and what we didn't do well. Turns out we're really good at taking histories because we do that all day, every day. We weren't as good at counseling. We covered some topics over and over and over again, and then we didn't cover other topics as well at all. At the time that we did this study, we did not cover social determinants of health. So we had a pretty antiquated process. You guys have a more advanced process than we did when we started. So basically the patient made a phone call, they made an appointment, they came into the appointment, they checked in at the front desk, they paid their copay, they sat and waited. Nothing to do, nothing in their hands. The MA would come and get them, bring them into the room, give them 2 pieces of paper. The patient would fill out the paperwork, and then the MA would hand enter the paperwork into our Epic system, while the OB provider sat around and waited and got frustrated. So now the OB provider goes into the room, they do everything: history, physical, genetic counseling, other counseling, answering questions, ultrasound, physical exam. The nurse may or may not come in at the end and answer questions. And then the patient would get blood drawn, and then the patient would go on to schedule appointments. So when we studied this, we found a couple of key things. The first was that when our patients did fill out our prenatal questionnaire, their visits were more complete. Problem is that only 73% of our patients actually got the questionnaire. So we were having some issues. Our process was not reliable. Our process needed to be improved. We also found that when patients engaged in nurse-led education, they had a more complete visit, but only 20% of patients actually had nurses involved in their visit. So what we did is we applied for a grant called the Clinical Effectiveness and Patient Safety Grant from our hospital and School of Medicine. And we put together these goals. And we tried to pick topics that we thought were high yield for our population, and topics that we were struggling to complete properly. We also wanted to integrate social determinants of health. So the original plan, my plan, was that the patient would come in, they would complete a medical questionnaire on an iPad. The information would flow directly into Epic. Then the patient would go to the exam room, they'd meet with the nurse, they'd get education, they'd get all of the screening, and then the provider would come in at the end and do ultrasound, genetic counseling, explain any other questions, etc. This did not work. It snowballed. So our first problem, and I think you guys may have experienced this as well, is that you cannot input your obstetric information into Epic if you are a patient. It doesn't work. It's not possible. So we went to Epic in Verona and we said why we want to do this. And they said, well, this module doesn't accept patient information. So it was dead in the water. So that was the first issue. We've since addressed that and they're redoing the module, and it's probably going to come out in the next 6 months. But I don't know if they'll have made the patient information part. But the module will be adaptable. The second is that the patients came late, the nurses were late, the providers were late, the whole thing snowballed. Now I had a bunch of providers complaining to me that they couldn't get this visit done. Their clinic was deranged, and it was my fault now because I was trying to make an improvement. So not so great. So we all got together, we sat down in a room, nurses, I had all the patient complaints, so I didn't invite them. Administrators, front desk staff, and we made a new plan. And what our plan entails is that patient calls and makes an appointment. They get a telehealth appointment and they get an in-person appointment. At the same time, we have a coordinator who sends them information about frequently asked questions in pregnancy. We then ask them to fill out a questionnaire, an electronic questionnaire. It's only medical. It doesn't have obstetric questions because we can't get that built in. But they answer the medical questionnaire and they're reminded to do that before the telehealth. Then the RN signs on with them. They do the telehealth. She does all the screening. She does all the education. She does all the history taking. And then the patient comes in within a week, has an ultrasound, has genetic counseling, has remaining questions answered, and gets their blood drawn and goes home. So we found this to be really successful. So we were really excited. The first 43 visits we calculated and we saw huge improvements in all of our goals. And as a result from this success, we just did this in the faculty clinic. So the faculty clinic is highly insured, a lot of patients, like a lot of doctors' wives, a lot of nurses' wives. This is our academic community. But because this was successful, the other groups wanted to do it too. So we started to expand the program, and that expanded, our significantly. So now we have an ethnically and racially diverse population. The languages spoken in our clinic are mostly English, Spanish, but 9% are other. I mean, they're languages like Rohingyan, they're languages like Urdu. They're not French, they're not Arabic. I mean, we have some Arabic, but they're not the common ones. There's some really distinct ones, and some of them are distinct dialects too. higher percentage of Medicaid, and now we're looking at a different health literacy level. Well, we did it, we implemented it, and we found a huge reduction, I would say huge, modest reduction in our no-show rate. So we're really excited about this because turns out new OBs are one of the #1 visits to not show up to an appointment. So our no-show rate went down from 23% to 17% with our resident clinic. And this was great because now we had extra room for other patients that we could add on. So we've improved access. Of note, if the patient didn't show up for their telehealth, we did reschedule them. We did call them. If we never got a hold of them and we rescheduled them and they didn't come to the next appointment, then we canceled their in-person. And that made me really nervous because I thought, oh, are we going to be losing these patients? Are we going to be losing these patients that don't speak English or don't feel comfortable? And it turns out no one ever showed up to the clinic. There were never people that came and thought that they needed to be there. And then when I would go through with care everywhere, I could see that they had gotten care elsewhere. So then the next question is, well, what about equity? So this is the area that we need to improve on. So we improved outcome for all populations equally. But this project did nothing for people presenting to the presenting in the second or third trimester. And the reason why is that we had allocated 30 minutes for the nurse intake. So if someone showed up at 24 weeks, we changed the intake. We excluded things that didn't matter anymore, but we also excluded things we didn't have time for because we replaced things like food education with third trimester teaching because now we were in a different category. And so while this project wasn't necessarily was not necessarily designed to address this problem, we're not going to make a change in maternal morbidity if we don't address it. The next, what about equity, is where have we widened the disparity? So when we first opened this up to all patients, there's a big concern because not everyone has internet. Not everyone has access to a smartphone. Not everyone feels comfortable speaking English, or not everyone feels comfortable navigating the websites because they're all in English. Now My Health Connection just added Spanish, but that was not the case when we started this. So we quickly moved to change our phone script to allow a telephone visit, an in-person visit, or the telehealth visit. And what we found was really interesting. A lot of our patients who don't speak English would do the telehealth, but have another family member by to help get them set up, and then we could get the interpreter on the line afterwards. Because there's always a transportation issue as well. And so this is probably our biggest success is where did we narrow the disparity? So before we weren't asking any questions about food insecurity, housing instability, transportation gaps, financial instability, or years of education completed. And so now that we have this information, the question is, what are we going to do about it? At this point, now that we're asking it, we have to bridge that gap. So our next step will be to see if our intervention rates go up. Are we seeing more social work consults? Are we seeing more addiction medicine referrals? So what's next? So like we said, quality improvement's never done. So right now we're working to maintain the current system. Right now, I'm just finishing analyzing the metrics for the faculty clinic, and the next step will be to measure the metrics for the entire clinic. Then we want to see if our interventions are increasing, like the addiction medicine and the social work. And then we'd like to look at morbidity outcomes to see if the patients that go through this before and after have any change in morbidity. And then we want to remove barriers to care and get prenatal care earlier into pregnancy. So is quality improvement the answer? And the answer is yes, but you have to evaluate the whole problem. Racial and ethnic disparities require continuous evaluation of the gap. Doing the project alone isn't going to address it by itself. Quality improvement takes a lot of time and a lot of patience and a lot of unplanned changes. And then if you're going to do anything new or innovative, you have to be willing to be misunderstood. And this one was really hard for me because I wanted to plan the project, I wanted to roll it out, and then I wanted it to just work. I just wanted it to be perfect. And I didn't want to rule it out because I didn't feel like I had it perfect. And so I kept trying to delay it and delay it and delay it. Finally, my practice director that worked in the clinic was like, we just have to try it. We have to do it. And the truth, you just have to like push it out. And the truth is that it's probably not going to work the first time, but it's not going to be as big of a disaster as you think it will be. Because once you get it right, everyone's happy. So this is a big thanks to my colleagues. This is my group. They allowed me to rearrange their clinics in an effort to produce quality improvement. And then a big thank you to you for coming today and listening. So the question is, make sure I have it right. If you look at patients and you try to discern whether or not it's the social issue or the medical issue, what do you find?
Yes, was there any racial disparity? Between the ones with a direct medical cause of the maternal mortality?
So I think the best way to answer this question, so I have to tell you, in my institution, I have not done that yet. So when I do, I'll let you know. We just implemented the entire program for every group in February. And so I'm waiting a full year to analyze more morbidity data at my own institution. And I don't think, it's hard to answer the question you're asking on a population base because we don't have the data. We were just like the way that we collect data. It's one of my pet peeves about this.
Okay, my second question is, what are you doing to the patients there in Colorado that 1 out of 5 to 1 out of 3 say they're mistreated when they come to the hospital for them? Now, I don't know what it is here in Madison. It sounds like a good resident project to me to find out about that.
Yeah, I agree with you. So I'm going to finish answering your first question and then I'm going to answer your second. So I think this slide really captures your question. And this was done. So basically, this is a large population database. So basically what this says is they looked at how many medical diagnoses women had, they stratified it by race, and then they looked at maternal morbidity. And so you can see that there are still discrepancies. The issue here is that they use the Elixhauser comorbidity index, which is, you may be familiar with this from the COVID. Basically, it's medical diagnoses with how likely you are to die being hospitalized for anyone, not for pregnant women. And so these are like real medical problems. They're not light things. And we can see that Black women who have, whether or not they have more comorbidities, they still have more maternal morbidities, which is interesting. So the next question, I don't think this is an easy topic, and I think it's a hard topic to talk about. I think it's a hard topic to listen to because no one wants this. No one wants to have patients feel this way. I have a resident that I'm working with who did an MPH, who did a really interesting project where she looked at interviews from moms in the NICU and the things that the nurses said to the moms. And I don't know that the nurses knew the moms were hearing what was said, but reading through her literature, I was really like, oh, yeah, I can see how this happens. Her paper, their actual paper isn't published, but I can ask for permission to share it with you because I was pretty struck with some of the things that I heard or read. Yeah.
Hi, Luther Gaston. I'm OB for the Nocturnus for UW. I think this is a significant challenge. First of all, we had a president previously who did not want to have implicit bias, and that could have been really deleterious to the efforts because we all walk around with bias. We have to have better empathy. And we have to really look at, are we providing the best care structure for patients? Meaning, when we look at our African-American women, their number one cause of death usually is cardiovascular cardiomyopathy. And so that, do we have the right care structure like I'd like to start here a cardiovascular clinic for women, because the number one cause of death for women, period, around the world is cardiovascular. So are we focusing on the right things for women in general, and then focusing on the right things that lead to death, particularly in Black and Latino women? The other thing in terms of what's very difficult for white people to understand is the constant daily stress of discrimination in this country. And I can't even go out on Father's Day and expect to just get a gym shoe because the person doesn't want to come up and serve me because, my wife and I walked out of the store. I mean, it was just absolutely ridiculous. I didn't walk in with any hostility or whatever the case is. We're tired of this damn discrimination in this country. I mean, just tired of it. I mean, and so we feel it. And imagine, I don't think that white people imagine a healthcare system where Black physicians are 5% of the physicians in this country. And basically you have it where if a white person had to go to 95% Black physicians, I mean, it's unsustainable. I mean, it's unsustainable. I think we also need to weed out physicians that are practicing disparate care. We know that even cancer care is different in some patients depending on ethnicity. And so if we can't practice guideline-based care across the spectrum, and that's where some of these elimination of variation come in, then we need to reassess whether we need to be in medicine. I mean, period. So we're not digging at some of the deep things that we need to really look at to improve this thing. And I applaud you doing the prenatal care, but we have to attack this hypertension and cardiovascular disease in the African-American community. And we can't do it doing the same kind of care we're doing now.
Thank you for your comment.
I have a question / comment. This was amazing. Thank you so much. I think I speak for my co-residents when we talk about that like initial prenatal visit with the patient with 10,000 problems. And it's like, how are we going to cover all of this? And you start kind of feeling like people are check boxes. And I think that for patients is really hard too. And then similarly you have, or I guess different, you have a patient who is like completely uncomplicated and you have this huge visit and you're like, well, I guess you're fine. So that's all we have. Is there any kind of like an intervention that you're aware of where there's like a pre-screening prior to that visit where you can kind of determine the complexity to help determine the appointment length, so that providers are, spending more time with patients who actually need more time? And I guess the next question is there billing implications of that? I would imagine the answer is yes. But I think at least like your revamp of the system is amazing and obviously very effort intensive. But if we like from our system can just like pre-screen people and say like this person has like all these things, in order to give them the best care at their first visit, can we give them a longer appointment? So I don't know if that's something that has been looked at or ever done anywhere else.
Well, just like even the cardiovascular, I wonder how many faculty practices or even use the CMQCC cardiovascular risk assessment screen at the initial prenatal visit. And that can actually be embedded into the EPIC. And I think we need to look, we may have some patients that are at higher cardiovascular risk to begin with, and we're not noticing those patients as they enter prenatal care. And so I think we have to really look at how we do prenatal care and how we look at cardiovascular care for women. We've got to invest in the care of women, and we've got to invest in the cardiovascular care of women.
Yeah, I agree with that. I think there's, so kind of putting both of the comments together, there's all these different screeners, right? But the real question is which screener is right for which person? And like, I completely agree that cardiovascular screening needs to be upped. And that's something that we've talked a lot about in our, actually our preoperative clinics. And we're starting to push that over into obstetric because of the higher cardiovascular risk that we're seeing. In terms of lengthening the visits, we tried to do this. We wanted to do this for women who didn't speak English. And because it's ridiculous to think that you're going to get through all of the information in the same amount of time when you're saying everything twice. I mean, that's like madness, right? But the main reason in our project, we have not addressed that. What I will tell you is that every nurse has an hour to do an intake. Most nurses are done in 30 minutes. We as providers don't get as much time, but now we only have to do like 5 things. So
Sure.
I think we have time for probably just one more question. Katie, do you want to ask your question here?
Just a couple weeks ago, I think we had a talk by Shiva Bidar-Silov, who I was thinking the exact same thing. Why don't we screen and make our folks who are lower English proficiency a longer visit? And she shared with me that had been considered, but a concern that as you change or try to alter visit lengths or make particular populations a longer visit length, you may accidentally worsen their access to care as you then are waiting for this longer visit type to be able to plug them into. So I don't know that it, like in my mind, I was like, okay, maybe we don't throw the baby out with the bathwater. Maybe there's other ways to think about it, but these other implications that could come along with it are also worth really carefully considering before we would like jump to the obvious, make the visit longer. The other thing that popped into my mind as you were going through your institutional data was the rates of individuals who were screened for genetic conditions and using that as a mark or as a thought process for how well we're doing with our delivery of care. The one thing that I've been learning as we've been working through a QI project for contraception over the course of a long period of time is trying to better understand the issues with coercion that patients may be experiencing, particularly Black patients. And I think about that as when I think about should the rates of people who get LARC options match by race, or should the counseling match by race? And so as we think about the markers that we use to track our quality improvement, being really careful not to say like, I'm hoping to like narrow the disparity by saying everyone has the same rates of getting a genetic test completed, but rather being just really careful that maybe it's the counseling piece that needs to match as opposed to like the test result number matching. Because I think we can also accidentally skew our patient experiences, disparities, feelings of coercion, et cetera, if we good-heartedly but accidentally maybe pick the wrong markers to track.
I think that's excellent. I think the hard part about this is that when we're talking about equity, we are going to provide something different for a different patient based on what they need. But how do we provide that, making sure that it's only to the patient's advantage, not to the patient's detriment? And I think that's exactly the challenge. But not being afraid to do it. I mean, I won't tell you that I don't have patients that have a lot of anxiety, that have 15 million questions at every single visit. I schedule them at the end of the day, right? I mean, we all do it. We all do it in our own ways. So why can't we do it for the people that need it? I mean,
Thank you so much for joining us today. Thanks everyone for your thoughtful questions. I'm sure if there's more questions, we can get those to Dr. Christopher and she'll be happy to answer those. But thank you everyone, and join me again in thanking Dr. Christopher for joining us.
thank you. Oh, thank you. And I'd be happy to take emails if you guys have other questions.